everyone. We're going to get started. So welcome to Centering Community Voices in Public Health with the Cross-Cultural Center. Before starting, I want to give a land acknowledgement. The UC San Diego community holds great respect for the land and the original people of the area where our campus is located. The university was built on the unceded territory of the Kumeyaay Nation. Today, the Kumeyaay people continue to maintain their political sovereignty and cultural traditions as vital members of the San Diego community. We are honored to share this space with them, and we thank them for their stewardship. And this was adapted from the UCSD Intertribal Resource Center. I also want to take a moment to introduce myself. My name is Sulema Villa. I go by the gender pronoun she, her, hers. I am a social justice educator and an outreach and engagement intern for the Cross-Cultural Center. And I'm also in my third year pursuing public health with a specialization in health policy and management. So before diving into the presentation, I want to give a brief outline of what we're going to cover today. So first, I'm going to define what is public health, so defining what it is and public health goals. Next, I'm going to go into what health disparities are by defining it and giving some examples. Third, I'm going to define community health workers by talking about their job, their documented benefits, training, education, employment, and funding. And lastly, I'm going to talk about community voices. And I had the pleasure of interviewing a community health worker from the San Diego area to really share the importance of community voices. I also want to go over some learning goals for this presentation. So why public health interventions prevent negative health outcomes and how they do it, how integrating voices have improved health outcomes, why community health workers are a special public health intervention in comparison to others, and steps on how to use your own voice to advocate for your community. Before diving into the presentation, I want to ask all of you what you know about public health or how would you define it? And to do this, we're going to do a Mentimeter. I'm going to drop the link in the chat right now for all of you and share a screen of all our answers. Someone shared wellness of the community. I totally agree. Disease, population, health, collaborative. And I dropped the link again in the chat for someone said they cannot see it. Some more people said health, population, everyone's health, community health, people-centered healthcare. These are all on topic and I completely agree. And we're going to talk about them a bit more in depth. Someone else said health equity. I totally agree too. You could continue dropping your responses, but all of these are on point and we're going to talk about them a bit more in depth. Research done on the surveillance and analyzing health data to create future health interventions. There's also outreach. This deals with going into communities and teaching about and advocating for different health services such as SNAP benefits on how to apply for it and how it would help. There's also screening, so doing an early screening for chronic diseases and cancer to see if we can stop the disease from spreading and prevent any long-term health outcomes. There's also health teaching, so just teaching about basic simple health behaviors and exercise or eating or sleeping or in our diet that we can implement to prevent future chronic diseases and other health problems and diseases. There's also social marketing. This is one we've all become familiar with through COVID-19. We've seen a lot of campaigns and marketing on why to get boosted for COVID-19 or to get your vaccination. Sometimes this can also include incentives to motivate people. to really follow these health interventions and why they're so important. And there's also policy development. Policy development is involved with implementing policies to prevent the public health also deals with the promotion of healthcare equity, quality, and accessibility. And as we'll talk about more in the presentation, healthcare is a difficult system to navigate, and we want to make sure that all individuals have proper accessibility and quality of care. Next, I want to define the branches of public health. So as I said earlier, when I first got into public health, I only knew about biostatistics and epidemiology. But as I got more into the major, I realized there's several different branches and each one has a different sector on how to protect health. So the first one is basic science. Basic science is concerned with teaching people easy, healthy behaviors to implement into their life to prevent future chronic diseases and health problems. So for example, healthy eating habits or diet, or how to exercise to prevent future chronic diseases. There's also health administration and their policy. So as I previously mentioned, some public health professionals will go in and implement policies or try to implement policies that could prevent future health problems from occurring. So for example, chronic diseases or respiratory diseases, as I had previously mentioned. And there's also community health. Community health is focused on the collective well-being of the entire neighborhood and or community. So making sure that everyone is okay. There's also biostatistics and epidemiology. So as we've all become familiar with the COVID-19 pandemic, we've seen a lot of public health professionals coming out with different research on how to prevent the spread and what can be done. And this also applies to other diseases that have previously occurred, and also just the analyzing and implementation of data for future health programs and interventions. There's also environmental health. So this focuses on narrowing down what environmental problems are causing health problems to larger communities. So for example, the dumping of hazardous waste, we want to figure out what's causing this and how we can stop it to prevent future health problems. And there's also health communication. So this is focused on just communicating with members of the community to make sure that they know what healthy behaviors they can implement into their life to prevent the spread of, to prevent future chronic diseases and health outcomes, and also just letting them know what resources are available to them. Next, I'm going to talk about some of the public health goals. So we always want to encourage positive health behaviors. This is just to always make sure that people are exercising properly and know what exercises to do, to make sure that they're eating healthy food that would benefit them. Also making sure they know proper sleeping behaviors to protect their brain, and also smoking less and drinking less. So overall, just making sure that they have a healthy habit in their life. We also want to prevent injuries. We know that injuries can lead to long-term health problems, so we want to make sure that we can prevent this and any future medical bills and costs. Next, we always want to focus on assuring quality and accessibility. So as I previously mentioned, the healthcare system is something really difficult to navigate. So public health professionals want to make sure that people can navigate it and they have cost-effective and appropriate care. And lastly, preventing epidemics and disease spread. So as we've all become familiar again with the COVID-19 pandemic, we want to eradicate, eliminate, and minimize disease. Next, I want to clear up a big misconception about public health. A lot of people use public health and healthcare as interchangeable terms. However, they are two completely different things. So public health focuses on preventing disease and injury in communities and populations. So we're more focused on preventative measures that can be taken, such as the health interventions we just talked about. So eating healthy, exercising, implementing policies and research that can be done to prevent these future health problems. Meanwhile, in healthcare, the problem has already happened. So they're just focused on treating the disease and or injury. So public health professionals are focused on identifying the cause of disease and disability early to implement solutions. To further illustrate this, a healthcare provider would treat a gunshot wound. Meanwhile, a public health professional would work to identify the systemic cause of gun violence and create solutions. To illustrate this a bit further, the difference between the two, I want to draw your attention to the left side of the screen with the table. So in public health, we're focused on the entire population, community, and or neighborhood. But in healthcare, they're more focused on the individual person and treating their wound or injury. In public health, we have a huge emphasis on preventative measures and disease, health promotion, policy development for the whole community. So again, on preventative measures that can be taken. Meanwhile, in healthcare, there's more focus on disease/medical diagnosis, medical treatment, and care for the patient. And lastly, our focus is always healthy communities and healthy neighborhoods. Meanwhile, in healthcare, they are more focused on healing the community and making sure that their wound is treated. Next, I'm going to go on to define health disparities. So a health disparity is a racial or ethnic health disparity at a greater or lesser extent between two populations. So to illustrate what a health disparity is, we're going to have one population that is low income and a minority population versus a white counterpart neighborhood. In the low income or minority neighborhood, we're going to have a higher than average rates of infant mortality. Meanwhile, in the white counterpart neighborhood, there are below average cases of infant mortality. So we can see in these two communities, there is a huge health difference between these two. And it's not a natural cause. This is actually linked to social or economic disadvantages for these racial and or ethnic groups. Moreover, the groups who are impacted by health disparities have been linked to historically disadvantaged characteristics, such as socioeconomic status, race or ethnicity, age, sex or gender, geographic location, disability, sexual orientation, immigration status, religion and or mental health. To further illustrate some examples of health disparities, I'm going to talk about some more, but this list is not limited to these only. Some other health disparities include mortality, life expectancy, burden of disease, uninsured versus underinsured, lack of access to care, rates of chronic diseases, and not just limited to these, obesity, respiratory disease, diabetes, and asthma. And these health disparities, as I previously said, are not natural. They are linked to social economic disadvantages. And in public health, we would connect this back to the social determinants of health. So these are conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcome and risk. So you're probably wondering what that means. So the environment that we are born into will dictate what our health outcomes will already be based on these 5 characteristics. The first one is neighborhood and built environment. So this is talking about if your neighborhood has stable housing and if people actually are able to pay their rent on time. If your neighborhood has access to transportation and is it affordable, can everybody actually use the transportation? It also talks about if your neighborhood is safe, if you can actually go outside for walks, if you feel comfortable enough to go to the grocery store by yourself and come back. It also deals if your community has recreational resources to go out and exercise. Do you actually have parks in your community? Do you have sidewalks that are safe to walk on and go for a run for? Next is health and healthcare. Health and healthcare is concerned with if you actually have health insurance coverage. And if you do, is there linguistic and cultural competency? Is your healthcare provider someone you can easily reach out to and talk to if you're having problems? Do they provide you quality of care? Next is social and community context. So this involves your community's social habits and how you guys support each other. Does your community regularly mingle with one another? Can you support one another? Can you reach out to one another? Is there community engagement? Is there any discrimination going on in your community? Or are there any extra stress factors that you deal with? Next is education. Education deals with if higher education is accessible in your community, or what is the average education in most people in your community? What are the language and literacy skills? Do you have resources to support your education journey or people that you can reach out to? Next is economic stability. So this is focused on if you actually have a stable job with a stable income. Is your income enough to pay your bills? Is it enough to pay your rent? Is it enough to meet basic needs such as hygiene and food, and also transportation? And some of the negative risks that have come out of health disparities include increased racism, discrimination, and violence in communities, less opportunities for education, for jobs and income, poor access to nutritious food and physical activity opportunities. So most communities will be in a food desert. It also deals with if your community is polluted it polluted in the air and water or other environmental resources? And if your community has less language or literacy skills in comparison to others. And as I previously mentioned, people of color and historically disadvantaged groups have the worst outcomes into health disparities. They are usually the ones that are most effective. So people of color, low income populations, women, older adults, children/adolescents, and individuals with special healthcare needs and individuals living in rural and inner city areas usually will be most impacted by health disparities. If you were to draw your attention to the right to the screen for the table called People of Color Fare Worse than Their White Counterparts Across Many Measures of Health Status, this table illustrates that people of color have worse health outcomes, with orange representing worse, blue representing no difference, and green representing better. We see that Black people have 90% of worse health outcomes, American Indian or Alaska Native at 17, Hispanic at 14, Native Hawaiian and or other Pacific Islander at 8, and Asian at 3. So again, these groups are historically disadvantaged groups that do not ask for these health disparities, nor should they have them either, but society has placed them on them due to their natural environment. Next, I want to share a video titled Michelle's Story, which is about her and her family combating health disparities and what they did to improve their health outcomes. And the video is 4 minutes and 18 seconds.
The world has got to change. I lived in a community that was so prosperous with doctors and lawyers and politicians. Now we have drug dealers and corner stores that they don't sell anything but the wrong things. You cannot deny the impact that it has on people's health. I have been in West Baltimore my entire life. As far as money, my mother didn't have any money. I don't want to say she was poor, I'll say low income. Poor we were though. In the 50s, we didn't have many choices as far as healthcare. The healthcare system then was limited. It was not good for us. And medicine costing so much that my family says sometimes, will I eat or will I pay for my medicine? Oh, I just love my daughters when they come over and we get together and we cook and prepare meals together. It's healthy meals. When my oldest went to college, she came back with a different diet.
Now what happens is if I do a meatloaf, it's turkey instead of ground beef. You know, I make spaghetti, I make chili, stuff like that. It's with turkey and chicken. We grew up, we ate pork. We ate bacon, we ate a fresh shoulder, we ate pork chops. I did not think it was not healthy eating, right? Because this is what we were accustomed to. I was in denial. I didn't want to face the fact that I was becoming a diabetic.
The impact is the fact that my family ended up with heart disease, emphysema, diabetes, cancer. My mother's sister, her daughter died of diabetes. She was an amputee. My mother died of a massive heart attack. And
to address health disparities, we need to understand why they exist, that they're not due to one single factor. They're the result of policy decisions we make as a society. They're due to the environment, health education, insurance and access to care, access to healthy food, and stress. Those stresses are actually experienced disproportionately by people who are poor and people who have been historically disadvantaged in this society.
Solutions to these problems cannot just be medical, it's systemic. And that means everybody has to get involved.
If we want a nation to be strong, the people in that nation have to be healthy. They have to be well. If there's anything that we can do to stamp out disparities, we need to do it by any means necessary.
Hi, Ms. Simmons. Here at East Baltimore Medical Center, most of the patients are underserved.
We need nice deep breaths in and up through your mouth.
Michelle is a terrific success story. There was actually a year where she had lost her job, and before she found a new one, she had no health insurance. And she still managed to buy her medicines out of pocket, paid out of pocket to come and have doctor visits. She was really invested in her own health. That's something that Dr. Cooper's research is looking at, why patients don't invest in their health like we wish they would.
The next thing on the agenda is the community update. So I'm going to
Michelle joined our community advisory board in 2011. We provide education to the community about health and about research. We offer training programs for community health workers. We can be sure that we are meeting the needs of people appropriately and that we're not leaving out certain groups of people that have traditionally not been included in conversations related to health and healthcare. Our strong relationship with the community is just essential. There's no way that we could do what we're doing without their input. And my work is just one of many initiatives here at Hopkins.
Ms. Simmons is a great example of what happens when we get it right as clinicians and as an institution.
I am a fighter. I am a believer. I stand for what's right. And what's right is people's health. And I will never give up as long as I have breath in my body. The world.
So Michelle's story is just one of multiple stories. Oh. Give me 1 second. So Michelle's story is just one of multiple stories of people combating health disparities. However, not everyone is fortunate enough to be able to do this. So next, I want to talk about health disparity impacts at the community level, at the generational level, and at the national level. So a huge misconception is that health disparities only happen individually. However, they can happen to the entire community. So for example, Americans living in rural areas are more likely to die from unintentional injuries, heart disease, cancer, stroke, and chronic lower respiratory diseases than their urban counterparts. And in regards to future generations, how healthy a woman is during her pregnancy and before will dictate how healthy her child will be. So for example, if a pregnant woman is experiencing large amounts of chronic stress due to not being able to pay her rent or other economic issues, her child is likely to be a preterm child, and her child is likely to go on to have long-term health problems. And at the national level, even though people think that health disparities may not have a huge economic impact, they do. Just last year, we had $93 billion in excess medical care costs due to health disparities, and $42 billion was lost in productivity due to health disparities. And if we were to actually reduce health disparities on a national level, we could save the United States $230 billion. So again, this emphasizes that health disparities. Someone in the chat stated obesity rates and access to healthy food. Someone else said access to healthy fresh food. I completely agree. Also diabetes. Yeah, a lot of my community members also have diabetes, including my mother. Someone else stated definitely food deserts and lack of transportation to those without cars. My mom. That's also my mom. Someone else did heart disease and relatives with less education on science, health, and exercise, definitely. And someone else did access to health education, nutrition, sex ed, etc. I also agree. These are all great responses that we'll talk about a bit more throughout the presentation. And feel free to continue dropping your responses in the chat. So next, I want to focus on what community health workers are. So what are community health workers? They are frontline public health workers for low-income communities and marginalized, selected by their own community, who act as a link to improve access to health and social services. So you may be wondering, what exactly does that mean? Community health workers are people from their own community, selected by community members, because they are deemed to have a cultural competency of the community's habits, such as eating habits, nutrition habits, what kind of food is accessible in the area, what's the religion of the area, are hospitals near, what are the rates of chronic diseases in the area. So community health workers are deemed to have a good knowledge of what health problems are going on in the community. So they are then selected to be as an advocate for the community on different resources and different resources that they can use to improve the health of the community. So they act to create connections between vulnerable populations and healthcare providers. And they also help patients navigate healthcare and social services system. As we previously mentioned, healthcare and other social service systems are very difficult to navigate due to language barriers. And they also act to educate healthcare providers and stakeholders about health needs. And what makes community health workers so special is, unlike previous public health interventions that simply come into these communities and intervene on them without really knowing much about their behaviors or their culture, community health workers are from the community, and they can provide a community voice on what needs to be done and what will actually benefit the community. And some goals of community health workers include advocacy, so advocating for community members on what will actually support them and what they actually need to improve health outcomes, outreach and enrollment, so speaking to community members on different programs that exist that they can apply for and that would benefit them, navigation, so helping community members navigate healthcare and other social services because language barriers exist and it's difficult for them to really know how to apply and what to apply for. Education, so as I previously said, public health focuses on teaching different health behaviors that are easier to implement, or on knowledge of different chronic diseases that people may not know they have symptoms for. So educating community members about them. There's also health services, so teaching community members about different services that exist that they can apply for. So for example, SNAP benefits, and most important of all, social and emotional support. So unlike previous public health interventions that do not provide real support or make community members feel seen and understood, community health workers come in and make sure that their needs are being met and they feel seen and understood. And I want to talk a bit more in depth on why community health workers are so special. So as I said, unlike previous public health interventions that simply come in and intervene on these communities, community health workers are from the community and they carry a deep connection and prior knowledge of the community due to being from the community. So they really know what needs to be done. And if you were to draw your attention to the bottom right of the screen with the table called the Community Health Workers Settings Continuum, it really demonstrates why community health workers are so special. So the community health worker is pictured in red, and they act as the middle person or the middle ground between the community setting and the clinical setting, including healthcare providers and doctors. So they are able to talk to community members about what they actually need and what they want seen in their community to help support their needs. And they can communicate these needs to healthcare providers and making sure that they're actually being met. So with a community member, we can make sure that people's needs are being met and the community has what they need. I want to talk a bit more in depth on why community health workers are so special. So you may be thinking, even though that they act as this middle person, how much better can they get? Well, they can also provide personalized diet. So if someone in the community has symptoms for a chronic disease or they're diagnosed with a chronic disease such as diabetes, they can go and help them make a personalized diet that would help them prevent their symptoms from becoming worse and also support their current chronic disease that they're experiencing. Or if they do not have a chronic disease, they can simply come in and just give them a personalized diet to be healthier. There's also coaching techniques for exercise. So if someone wants to get into exercising in the community, but they don't know where to start or what exercises to do, community health workers could come in and make a whole routine for them and teach them different exercises to do. And they will stay by their side to make sure that they're actually doing them properly without straining their body. There's also navigating access to healthcare. As we said, healthcare is a difficult system to navigate, and there's a lot of terms that may not be understood, and there's a lot of language barriers. So community health workers would come in and teach them how to apply and how to navigate the system. And there's also grocery delivery. So during the COVID-19 pandemic, we had a lot of elderly people who did not want to go outside to get groceries for themselves because they did not want to risk an infection or infecting their family. So community health workers actually went and got the groceries for them and delivered them. But even without the COVID-19 setting, community health workers can still do grocery deliveries for people if they do not have accessible transportation to go themselves, or they physically cannot get their body to the grocery store to do it. There's also vaccine access, and this goes beyond just making sure people get the vaccine. This actually means helping people make an appointment to get a vaccine because they may not know how to work the system since it's technology advanced, and a lot of these people are elder or not familiar with technology. It also means going to their home and getting them to the vaccination site to make sure that they receive it and following up with them to get their second dose. There's also food, so making sure that people do have food at their home to provide for them and their family, and making sure that they have SNAP benefits if they're eligible, and housing, so making sure that people have stable housing, and if they are in risk of being evicted, they can help them apply for a grant. They can help them look for mutual aid to make sure that they can maintain their housing. And there's also quality care. So making sure that people are receiving good care and making sure that they feel seen and understood. And lastly, health information. So just communicating different healthy behaviors that they can integrate into their life and different services that they can apply for. So next, I want to talk about the benefits of community health workers, because on the surface, they sound too good to be true. However, they are that good. So with community health workers, some expected benefits were that there's going to be increased access to services, including those that can improve factors related to the social determinants of health, and also improving the entire health of the community. However, some documented benefits that have been seen have been that disease management for diabetes care and hypertension and cardiovascular disease has improved. There's also increased primary health care, reducing hospital admissions, and improving post-hospital care. And also African-American patients with diabetes revealed a 40% decrease in emergency room visits and a 33% decrease in hospital admissions. Some other benefits, as we talked about, there are a lot of economic losses due to health disparities. However, with the implementation of community health workers, we have seen a return investment of $2.28 for every dollar spent on expensive inpatient care interventions. And we've also seen patients with one chronic health condition conclude that interventions are cost saving, and indicated interventions are at low cost at $1,500 per patient yearly. And 42% of the randomized controlled trials in this study where all this data comes from stated that measured emergency doctor visits, hospitalization, and/or urgent care visits significantly decreased due to community health workers. So again, we're seeing an emphasis of community health workers having great benefits and health outcomes on the communities. Next, I want to talk about the employment of community health workers across the United States. So if you see on the left side of the screen of the map titled Employment of Community Health Workers by State as of May 2021, the dark green states represent states with the most community health workers, and this includes California and Texas, and states with the least amount of community health workers, the light green states, such as Wyoming and Kansas. And right now, the states with the highest employment in community health workers, if you were to turn your attention to the right side of the screen, include New York with 7,750, California with 6,740, Texas 4,000 with 690, Washington 2,000 with 860, and Ohio with 2,300. So despite how huge these states are and the populations they have, the community health worker ratio to populations is not enough. They're not employed, not enough employed community health workers to match these populations. However, overall employment for community health workers is projected to grow 17% from 2020 to 2030 and is also one of the fastest growing occupations. And beside this, 16,100 community health worker positions are expected to be opening up in the upcoming years. So this is great to see that there are more positions for community health workers opening and that they're receiving more recognition for their work. However, this also brings up the other issue of community health workers not being paid enough for their work. So right now, there are 61,010 community health workers employed. However, they only work for an hourly wage of $22.97, and with an estimated mean annual wage of $47,780. Another study concluded that community health workers only make $46,590 as of May 2021, and this annual income that community health workers are making is not an accurate representation of the work that they are producing for these communities. Moreover, it is not a livable income to make sure that their basic needs are being met. It's not enough to pay for housing, for transportation, for food, and for hygiene products, moreover to pay for rent. So despite the amazing work that community health workers are doing, they are not being paid enough for their work. And I want to emphasize this a bit more with this other graph with the annual mean wage of community health workers by state as of May 2021. So again, we see that even with the highest paying states such as California and Nevada with 50,000 to 300 to 69,000 to 370, it's still not a high income to pay for their basic needs and or their services. And this also brings up another huge issue of that 20% of care workers live in poverty and more than 40% rely on some form of public assistance. So even though community health workers and other healthcare providers are doing immense work that are benefiting these communities and having huge economic benefits and health outcome benefits, they are not being paid enough for their services. And I want to emphasize that this wage gap demonstrates the need to increase pay to support community health workers' personal care and home health workers to have a living wage. And next, I want to talk about the funding for community health workers. So one reason why community health workers are struggling so much to be reimbursed for their services properly and to have a living wage is due to their sources of funding. So the first one is the state plan amendment for reimbursing preventative services, which I'll talk about more in the next slide. And there's also defined reimbursement through section 115 waivers. So each state has different waivers under section 1115 that they use to pay community health workers, but some states will manipulate these contracts to not pay community health workers enough for their services. There's also reimbursement through managed care contracts. So again, community health workers are under specified contracts that only reimburse them for specific services, even though they may be doing more than what's on that contract. There's also federal, state, and foundation grants. And lastly, insurance companies and or other businesses may provide funding support for community health worker programs. Next, I want to talk about a huge step forward for community health workers, which was the Center for Medicare and Medicaid Services Reimbursement. So this was an authorized reimbursement for preventative services by a community health worker if the services had initially been recommended by a physician and or licensed practitioner. So previously, community health workers were not being properly reimbursed for their services. Moreover, if they wanted to receive a specific service for a community member, as pictured in the graph, in the photo below, first it had to go to the primary health center, and next the supervisor, and third the community health worker. So there was a huge gap in getting the services to the community health worker and the community member, and this could lead to future health problems. However, through the reimbursement, the primary health care center can authorize the service, and it can directly be applied to the community health worker and community member to make sure that they are receiving it at a faster rate. And this took effect on January 1st, 2014, and we're starting to see more of their services being recognized and some of the positive outcomes that have come through with this reimbursement, which I'll talk about in the upcoming slides. So again, I want to emphasize why this reimbursement is so important. in the healthcare system, since non-licensed practitioners can be reimbursed for preventive services provided by a licensed practitioner due to lack of prior, so services can be reimbursed by a licensed practitioner, and moreover, due to lack of reliable funding to expand community health worker programs and integration into the healthcare system, this reimbursement will address these major problems. And this is just a map to illustrate which states actually reimburse community health workers. So right now, the purple states represent states who do not reimburse them, such as Washington and Oregon. States that do reimburse community health workers, but not through, who do reimburse community health workers through managed care systems include California, Nevada, and Utah. And states who do not reimburse community health workers at all include Texas and Arizona. And there's future hope for community health workers. As of right now, the Department of Healthcare Services is adding community health workers service as a Medi-Cal benefit starting this year on January 1st. And this is a huge step forward since Medi-Cal is one of the huge insurances used by people, so it'd be easier to access and implement. And the budget for community health workers was increased to 16.3 million and is expected to grow to 201 million by 2026. So we are seeing community health workers receiving more funding in the future so they can provide more preventative services and programs for community members. Next, I want to ask all of you if you believe your community can benefit from a community health worker. I know my community really could have benefited from a community health worker due to my mom not knowing English. She couldn't really apply for health insurance, nor did she really know how to get around town. And as a result, she got her license late in life, but now she has it. But if she had had a community health worker, she could have applied for these services sooner and also had help. Someone in the chat said, definitely help for those without insurance coverage, especially. Yeah, I completely agree. Someone else said, we could use advocates for how to properly fill out applications for health insurance and programs like food stamps in my community. I definitely agree. Someone else said, yes, definitely, especially with mental health services. Yeah, I also agree with that. I feel like we've seen a rise in mental health services needed in communities. However, there's not much help on how to do it. All right, you can keep on typing your responses in the chat. Feel free to. I'm going to move on to community voices. So as I said, I had the pleasure of interviewing a community health worker from the San Diego community. But before diving into the community health worker I got to interview, I want to share a video of the organization that he works for and what they do on a daily basis. They are the Union of Pan Asian Communities in San Diego, and this is a 3-minute and 48-second video.
I'm Dominic De Los Reyes. My pronouns are he and they, and I work at UPAC as the program coordinator for community health worker communication and outreach services. It started in September of last year, 2020. We got funding from the County of San Diego in support of the Live Well San Diego vision for safe and healthy communities to be able to extend the communication being put out by the county, providing accurate and timely information about COVID-19 and resources for pandemic relief so that it can reach multiple different communities that speak multiple languages and have different ways of communicating so that the message can get to the people in a way that would best suit them. We are a team of community health workers, and we are from the communities that we're reaching out to. So we know the best ways to be trusted messengers with accurate COVID information so that folks can make the best informed decisions for themselves about things like the COVID vaccines and how to help keep themselves and their families safe. There can be a lot of obstacles for people who either don't speak mainstream languages in this area, they speak other languages and need translation. But because the nature of the pandemic is that it's changing so fast, it's one of our barriers is to get out pertinent information in a timely manner in the languages that our communities speak. We also need to be able to accommodate the different ways that communities like to receive and give information. So it's important for us to figure out what are the specific needs of specific communities and match resources to those needs. We really need to take cues from the people from the ground up and give them opportunities to speak up for themselves. Printed flyers are still quite popular, especially if we're going to be meeting people out in the public, say in front of shopping centers, or even doing traditional door-to-door knocking, meeting people where they're at. We want to encourage folks to be their own health, right? Fast changing. It can mean a lot to folks to know that we're in this together, that we're a community and we're helping each other, and we're looking out for each other. So I'm really grateful that through our UPAC program, we're able to schedule many, many appointments, meeting people where they're at, and also knowing what motivates people, what do they care about, what matters, such that they would be willing to change behavior in a way that helps everyone on a larger social scale. The core is our people, our staff. They're amazing, and they are so good at developing immediate trust with people that they're offering services to, or just trying to help navigate these sometimes very difficult decisions people are having to make, and helping with adjusting to changes that the pandemic has forced upon all of us. This program was only meant to be a temporary educational outreach project during the pandemic, but it keeps getting extended as the pandemic keeps going on. So on one hand, I'd love for us to not have to have this program because it would mean that the pandemic is over and people don't need that extra support. However, I feel like we can really create a lot of good while we're here. I'm Dominic De Los Reyes.
So next, I want to move on to the community health worker interview I got to do. So I got to interview Julian de Obsinia, and he goes by the gender pronouns he, him. So he started as a peer support educator, but became a community health worker once the COVID-19 pandemic began, and he stayed in this position till now because he really fell in love with it. And I also provided a QR code for the organization that he worked with on what the video was about, if you're interested on seeing a bit more. So the first question I asked was, what motivated you to be a community health worker? And as the video showed, even though they focus on COVID-19, he stated that in his job, he realized that this job is more than just COVID-19. It also ties in with mental health, people getting evicted, food services, and many other. So it demonstrates that COVID-19 is not just tied to one thing. There are other basic needs that need to be met to make sure the person has a proper well-being. And he also stated in this position, he felt that his opinions and experiences were valued. I also asked, what does a day as a community health worker look like? And he first explained that his team is filled with different people who all have different specialties, but he called himself the errand monkey, who was good at doing the small tasks to support large events. So for example, someone in the community was going to travel to Thailand to see their family for the first time, but they didn't know anything about the traveling regulations. So Julian taught himself them to make sure that they can have a safe travel and no issues came up. And also in planning outreach events, he's the one who will learn small details to make sure that everybody's culture was being met. Beside this, I also asked, what are some of the positive health outcomes you have witnessed during your during your work as a community health worker. And he stated that while he was a peer support educator, there were certain things he was not allowed to do under his contract. And there was a certain person he really wanted to help but couldn't. But as a community health worker, he was able to go back to this person and actually help them get their driver's license, to get a bus pass, to apply for EBT. So it was going back to this person and making sure that all their basic needs were met that really made him happy and really solidified that he wanted to be a community health worker and that he was proud to do this work. Beside this, he also stated as a community health worker, he learned that he could argue for different services. So as I previously said, even though his organization focused on COVID-19, he was also able to argue for mental health, for housing, for food. He also stated he argued for bus passes and making sure people got other basic services. I also asked him, what have you learned from your experience as a community health worker? And he stated that as a community health worker, we are the community and I am the community and anyone I'm servicing. So this really made me feel happy and I was really his passion for his work. And lastly, I asked him, what do you think community health workers need in terms to continue or expand their work in communities? And this can be funding, laws, recognition, or etc. And he instantly said, funding. We need funding. And he stated, even though he is able to provide certain services, he has paid out of pocket for some. And he has no issue doing this because he's proud to help his community and making sure that they have everything they need. But it shouldn't have to be that way. There should be enough funding to make sure that everyone's needs are being met. He also shared that it's frustrating that you can't do more as an employee in comparison to a stranger. So he was talking about, even though he knows he can do more as a person for these people under the contract of a community health worker, he's not allowed to. And so he has to watch as he cannot do more for this person, even though he knows he is physically capable of doing it. And lastly, I just want to share some tips on how you can incorporate your own community voice. So always being open, transparent, and responsive, act on feedback, highlight strengths of the community, be aware of your biases, be generally inclusive. And one last question is, what resources does your community need? Someone stated in the Q&A, to clarify, who are community health workers employed by? Is it a government thing or private ones? Community health workers are employed by the city with different organizations. So with the video we just saw, this is one in the San Diego area. So they're mainly employed by the local government. And somebody else stated, what organization does Dominic work with? It's the same QR code I supplied for Julian, and I can go back to that. Actually, it's in the QR code with the resources, and I can share it to you too. I just want to say thank you again for all of you for coming and sticking around for this presentation. I hope you enjoyed it and learned something. And the QR code to get connected to where Dominic works is this QR code right here. Thank you again for coming, and I hope all of you have a great day. I also want to share some upcoming programs for the Cross Cultural Center. We have Wellbeing and Basic Needs actually tomorrow, and Abolition Medicine and Transformative and Restorative Practices next week. The recording will be posted to our YouTube channel in a couple days. It should take around 3 days, and if it still hasn't, you can email us at cccenter with this email right here at ucz.edu. And for any other questions on the QR code or what organization Dominic worked with or anything that you wanted clarified.